Welcome to Heart Failure Unfiltered. My name is Nick Hartshorne-Evans and I'm the founder and CEO of the Pumping Marvellous Foundation, the UK's heart failure charity. This is a special edition Beat Breathlessness podcast. Beat Breathlessness is an initiative with Everton in the community, University of Liverpool, the Pumping Marvellous Foundation, all supported and funded by the British Heart Foundation. Today, we will be discussing Out of Breath, real stories, science and technology, and solutions for breathlessness, a podcast about heart failure and why the simplest ideas often save the most lives. This podcast asks one question over and over again. Is it time to think differently about breathlessness? Because if we don't deal with breathlessness, patients won't be the only ones to be impacted. Well, welcome everybody. We are at the Liverpool podcast studios with some inspirational, amazing guests. So let's start with Amy.
Hi, so I'm Amy Powell. I work at Everton in the community and I am our health screening lead.
Amazing. Gail.
Hi, I'm Gail Rook. I'm a long-term conditions delivery manager at Cheshire and Mersey ICB for the NHS.
Okay, Rajiv.
Hi everyone, Rajiv Sankaranarayanan. I'm a heart failure cardiologist from Liverpool University Hospitals, and I'm also the clinical lead for the BEAT Breathlessness hub at Everton in the community.
So let's start with you, Rajiv. How do we diagnose breathlessness?
So the most important bit is to ask a few more questions as to what's causing breathlessness, when do you get breathless, is there any cough? So I think a detailed history as to what the symptoms are, what the context is, when did it develop, was it sudden, was it over a few weeks or months, what are the risk factors, we go a bit into detail about smoking, any potential heart problems. So I think that's very important. Then a detailed clinical examination following that, and then going on to investigation, some of which are simple blood tests.
Okay, let's rewind a little bit. Before they see the doctor, self-diagnose breathlessness. Sorry.
Yeah, so again...
I'm not saying diagnose, I'm saying recognize.
Recognize. So
when
I think,
it's not normal.
Yeah, so the self-recognition is important, not assuming that it's part of daily living. And again, keeping an eye out for what can be abnormal. So if it's following a chest infection, for example, and you're left breathless for weeks and months after that, that's not normal. You can have a bit of fatigue after, but it's not normal to remain breathless after that. And again, not assuming that it could be just as a part of aging, for example. Weight gain can make you breathless due to the associated lack of fitness, but there can be other conditions which can come along with the weight gain as well. So it's about self-analyzing the context, but not assuming that it's part of normal and letting it sort of pass. So speaking to your GP, your practice nurse, simple BEAT acronym, breathlessness, exhaustion, ankle swelling. It's time to speak to your GP or nurse and ask for a simple blood test. So it's about being self-aware, but also taking the next step and speaking to a specialist.
Why is breathlessness such a key sign or symptom or red flag for heart failure or respiratory conditions?
Mainly because it could be the culmination of one or both organs being affected. It could be the fact that there are other things. I mean, there are people with chronic kidney disease who can also be breathless. So it could be the culmination of one or more organ. But it's important because taking a breath is an important part of normal life, isn't it? So not being able to do that should be seen as a significant problem. And that's why it's a red flag. And it can lead to something which can be an acute condition where you're suddenly very, very breathless and can end up in A&E or being unwell enough to pass out. So it should be a red flag, but it can be a marker of one organ or more than one organ in the body, the heart, the lungs, an organ like the kidney. So that's why it should be a red flag for everyone.
So what myths delay people from seeking help?
So it's some of the things we've touched on. Like I said, people don't want to be diagnosed with a health condition for the right reasons. No one wants to have a label of having a problem like heart failure.
And is that because they have uncontrollable consequences because they don't know?
Yeah, I mean, it's just normal human emotion, isn't it? No one wants to be diagnosed with anything that's wrong with the body. So you want to sort of put that away as much as possible, put that in the back of the mind, delay seeking help. Those are all normal human emotions. However, in doing so, you could end up with two things. One is you could be breathless for a while, not do things that are part of normal daily living. And that could go on for weeks, months, sometimes years. But then this is also a treatable condition. And if it's not treated, you could end up so unwell. You could end up in hospital in an A&E setting, or indeed, unfortunately, die if it's left too long. So it's about recognizing the consequences of delaying that seeking help.
So here's the interesting thing. How do we use technology to help improve the, I would say, probably not we could use it to improve recognition, but actually when somebody presents, what have we got in our armory?
So a few simple things. So historically, these tests, I mean, obviously, like I said, we have to start from doing the basics, right? Like I said, speaking to the person, taking the detailed history. So it's not shortcuts which go away from that. Examining the person, listening to their heart and lungs, looking for signs of fluid overload. So those things still need to be done. But simple things like getting an ECG, we can get that on the fingertips, for example, as opposed to having to go to the hospital.
How much is that? What, 99 quid from Amazon?
Yeah.
Gives you sort of
it's a simpler, quicker version. It can be done at scale in the community, for example. It's not a substitute for a 12-lead ECG, but it's available at the fingertips. We can do that. We can do simple point-of-care finger stick blood tests, so that can pick up. So there's a peptide called as NT-proBNP that can be done with a finger stick blood test. It's available within 5 to 10 minutes. Historically, and even now in certain parts of the country, that blood test is taken from a venous sample, goes off to the lab.
That's in the arm?
Yeah, from the arm, and goes off to the lab, can take a few days before the result is acted on. So all of that matters. Mm-hmm. So if you get the result then and there, and if that blood test is normal, you can be 90-95% certain in the right context that the person does not have heart failure. And that's very, very important to know.
But now we're moving into a period when you can take that a couple of steps further, can't you?
Yeah. So if that blood test is abnormal, the peptide level is raised, so there is the suspicion of heart failure, we can use an ultrasound scan of the heart, along with AI, and a trained professional can acquire the images. It's interpreted by AI. The result is available within 10 minutes. So it's that taking the context, the beat to treat. So you've got the full diagnosis within 60 minutes, and you can start life-saving treatment within 60 minutes.
Yeah, and I think the important thing is that there's definite oversight. It's the oversight, it's the interpretation of the results that's important. That, it's not an untrained eye that looks at it. And they're always, we're not relying on AI just to, it's AI's presenting the information to you, and then you make that judgment. So identifying breathlessness, we can now move it at pace in a one-stop shop, maybe. So that brings us on to, I suppose, why we are doing this series of podcasts with Everton in the community. And this is a British Heart Foundation funded programme, which is fantastic because it shows that there's national buy-in to this. Amy, tell us about the Beat Breathlessness programme and what you're doing.
Yeah, so the Beat Breathlessness project is the first of its kind community screening hub specifically for heart failure and lung conditions. So we're able to do those tests that Rajiv mentioned, so the finger prick blood test to be able to detect if the heart's under strain, but then also we're able to then offer on site the ultrasound of the heart to be able to see if that actually is heart failure. So as you mentioned, the one-stop shop. Everything's under one roof. We've got someone that can walk through the door and can be screened. They can then be followed up by either respiratory testing for that breathlessness symptoms, or they can then be followed up with the echocardiogram to detect if it is heart failure. But obviously, while they're there, then they've got that access to an umbrella of different services. So we're able to offer all of that under one roof, essentially.
So personally, if I did what you did, I'd be buzzing, yeah? Because... what do those people feel or what they say? What's the feedback?
The feedback's been amazing so far. I feel like because it is based in a football club, we've got that sort of special standpoint in the community where people come to us and they feel like they're giving back as well. They come to us and say, I'd like to give back to any initiatives that you do, but also been a bit concerned because of X, Y, and Z. So then they've got that, you're breaking down barriers, so then they're able to come to you with any of their concerns and able to ask for support and feel confident in doing that.
That's amazing. And it's not just the People's Hub, is it?
No, so we're actually spread across Liverpool. We're expanding the hub sites. So
this is where the British Heart Foundation funding helped to do that from an initial... We did. I know you. I don't think you were with.
I was there at the time.
Oh,
yeah.
Sorry, apologies.
That's fine.
but that it's from an initial sort of project that was very embryonic, and now we're taking it across 3 sites. Talk to us about
Yeah, so obviously that was the pilot programme. So we were able to establish that this model works, and now we've been able to expand it due to the funding that we've received. So we're acting as like the North Liverpool sort of clinic, and then we've been able to expand it within Central Liverpool as well as South Liverpool, so expanding our reach essentially, and that's with partnership with the lovely NHS that's been able to do that.
Yeah, what I've seen is that the NHS really want to work with Everton in the community and the key delivery partners, which are University of Liverpool, Pumping Marvellous Foundation. And, I've been really impressed with how enthusiastic everybody is. And that tells me it's not always about money. Rajiv, have you got any more to add to that in terms of, the clinical aspect and...
Yeah, so I think it's about like what Amy was saying, harnessing the reach of Everton Football Club. And what we found from the pilot in 2024 is we can access a population who probably respond a bit more to communication from the football club. And that's because historically, like we said, people don't want to access healthcare services unless they absolutely need to. So there's that delay in reaching out to a clinician, a doctor, a nurse. And people put off their symptoms and the diagnosis to the extent where they historically used to pitch up in A&E in extremis, feeling very, very unwell. And what we found from the pilot is in a traditionally non-healthcare setting, we could access these people. They come to speak to a clinician, have simple tests, and they're not as put off as opposed to going to a hospital setting, struggling to find parking, for example, spending hours in a clinical setting. So that was a lot of value, and it's about taking the specialists. We're not taking shortcuts. We're taking the specialists out into the community. So the team involved is a heart specialist nurse, there's a respiratory or a chest specialist nurse, there's a consultant cardiologist, myself. And there's a chest physician who's also overseeing this. So it's about ensuring that the specialists oversee what happens in the community, go out into the community where these people are, where they can be accessed in a more sort of disarming kind of setting. And it's about taking the tests out to the community as well. So all these tests, the AI-aided echo, AI-aided spirometry. So these tests can go out in a community setting where the people are, and where they can have the tests in a quicker fashion, but it's not replacing. So if these people go on to require other tests, the MRI scans and angiogram, etc., it does not replace the need for that. So it's sticking to standard care, but making sure that these tests are available in a quicker fashion, because even in other parts of the country, people are waiting weeks to months to have that simple
months
blood test, simple ultrasound and things like that. And we're making sure that we're going out and being a bit more proactive in a way, asking people, are you breathless? And if you are breathless, here are the tests that can be done in the community.
So, interestingly, you could take this into other sports. So, rugby league, which is a northern sport, but I go and see rugby league a lot, and I'm sure doing this sort of thing with rugby league clubs would be interesting, and of course rugby union, and any other mass spectator sports. But Amy, I think you're ideally placed to answer this, but why are football clubs? I mean, Everton is, one of the two big clubs in Liverpool, and it's tribal. Mm-hmm. I know that, I'm from Liverpool, but it's quite tribal, and there's got to be some like emotional hook to. So why are they such powerful health partners?
I think exactly what you mentioned there. It's part of our culture. Whether you are a red or a blue, it's a part of culture. Everyone recognises football. We all have that sense of belonging to a club, or even its place in our community, especially with Everton in the community being in L4. It's quite a deprived area, and that's where we've got that reach there to the people that need it most, like Rajiv said. But as you said, like other sports and other clubs, for example, are able to do this type of thing because they have the same standing in their community as well. It's just about utilising what they already have in that community and reaching out to partners to be able to basically just get it going. We've proven that it can be done, and it's just getting it going, really.
It's just using the power of the brand, isn't it?
It is. It's the power of the badge. That's exactly what we say. Everyone recognises the badge, and it brings some comfort to people to know it's something that they recognise and they've always felt comfortable around it. We just won't do blood pressure testing on a match day is something that we've stopped doing.
That's probably quite appropriate, really.
Yeah.
It's like one of the most famous football manager said football's more than life and death.
Yeah.
I was wondering where you were going with that one. Yeah. This is where it turns into, it's not a podcast about heart failure or respiratory. It's a podcast about football. But I do genuinely think that. And, I think it's a very... So we've done it around the country. And, I mean, we had 957 people turn up at Stoke City Football Club. And the police had to stop us with the event because the A500, I think it was, A50 or A500, I think it was A500, was starting to get jammed up because people were queuing. And what I saw was what I see with Everton. Mm-hmm. Slightly differently, because 957 people in one day was a bit like chaotic, but it was very well managed, of course. Was people were coming in because they saw they hadn't, people that maybe who went to the match but never saw each other, but knew them 10 years ago. And it became a community thing.
Yeah.
And I think, certainly from a man's health aspect, where I think there are problems with men presenting, and it's very much, I think we talked about this, where people try and normalise it, but it's not normal. That actually football, because of its tribalism, and it is tribal. I mean, it's not just Liverpool, Everton, is it? I mean, it's not just Premiership clubs. It's not. I mean, football is quite unusual, and it is just tribal. I mean, that's the best way to explain it.
One of the events, Nick, you'll remember, there was a chap who drove up or his wife drove him up from Wales, just because Everton had called. So yeah.
Yeah, I mean,
Gosh,
that's powerful.
Yeah.
It doesn't. I mean, we're talking about national, global clubs here. They're supported around the world.
Yeah.
And it's great that Everton, the community. It doesn't surprise me that you've led this, is leading this, and maybe we'll have a premiership of football clubs of who gets the best results. So, right, Gail, how does delivering care in trusted spaces change what we've just been talking about, engagement? I mean, you're the expert. You are the expert at this.
Yeah, it's really important that we do it in places that people feel comfortable to kind of go for these things. Patients talk about, I probably need to see my GP, but that takes time. You have to make an appointment. Whereas what we do in community spaces where people can come at a time that's convenient to them. And then because it's in somewhere that they recognise and feel comfortable, if it's the club, if it's the community centre, then they can talk about the signs and symptoms that they've got quite openly. They're not kind of worried about what the outcomes are about having a long-term condition. It's in somewhere that they feel like they can talk about these sort of things. So they don't feel that anxiety that you would about going to a hospital. You've had to park, you've had to try and find the location of the place. We do things in local community centres so people just turn up to somewhere, they go all the time, they see all their neighbours, and actually they've just come just on this off chance to get checked and just see what this is today, and is it going to be something that then later I'll have to worry about car parking and stuff, but today I can just pop in, get the checks done and go away with the result if that's what's needed.
Do you feel as though it's a paradigm change in how we can do things differently?
Yeah, I mean the NHS talking a lot at the minute, isn't it, about this left shift, about getting hospital care out into the community, and I see that being really important. We've got to bring things to the people rather than asking them to come to us. That kind of gives us time to talk about the signs and symptoms of everything that they've got going on. Quite often people's health takes a backseat if they've got debt in their lives, if they've got damp in their house. Health just isn't important to them at that time. But actually, if they've come to the community centre to talk about that, the other thing that we can slip in there is we can talk about their health and kind of get those checks done there. And then, we've not got to worry about them having to take time out of their day, get the kids looked after to go to a clinical setting. They've come to talk about other things. So it's a great time to kind of catch them.
And do you see that, Amy, in terms of, it's quite a difficult question, really. But do you actually see that on the ground, that it's actually more convenient?
Definitely, yeah, especially having that opportunity, as you mentioned, just take it into the community. It's somewhere that people are familiar with and they know that I know where to park, I know how to get here, I know the faces that I'm going to see, they know what to expect. And a lot of that is a huge barrier in terms of stopping people from going to hospital appointments, is that it's nerve-wracking. They might have a negative association with going there in the first place, but they've got positive associations with going into the community settings. So getting them there is the first step. And what Gail mentioned, that wider wraparound support is something, as you said, once you've hooked people in, then people might say, well, I need support with with mental health, living with a long-term condition, being more physically active, meeting new people. These are opportunities that we can offer at Everton in the community, and just getting them through the door in the first place opens up that gateway, essentially.
How do you scale this? How do you do it?
We have to work with our partners. You know, we can't do this on our own. There's lots of partners here today. Everton,
because we need to do it at speed, don't we? Really?
Yeah. And we need to sort of, embrace that this is a change that people are looking to do. You know, we really are looking to put stuff out into the community and use those settings. And so we just need to embrace that change. But like I said, use our partners. Everton in the community are a great partner for us. But use our clinical staff as well. You know, we've got our newly formed primary care neighbourhoods, and we need to sort of work with those, because like we said, it's not all, people aren't always coming for their health. They're coming for other things first. But actually that's when we can start to tackle the health, and we need to do that, like I said, with our partners.
Because it's lift and shift, isn't it?
Yeah.
You can lift it. What you've achieved, what you're doing, you can lift and shift it with very little friction.
Yeah.
Is friction a big issue?
Yeah.
You know, friction in change. Do you think, tell me yes or no or whatever, or answer how you want, but do you think that there's an acceptance that this needs...
Yeah, absolutely. You know, waiting lists are the highest they've been in such a long time. And, we can diagnose somebody with heart failure within 60 minutes in a community setting. You could be waiting 6 to 8 to longer in the clinical setting. And that's just not good enough for people. They want to get these things sorted quickly and at a time that's convenient to them. Let's not mandate them to come to us to an appointment. Let's bring these appointments to them.
And especially those waits are magnified. So for a condition like breathlessness, it can be seen as what we call as nebulous. It can have multiple causes. It can have overlapping causes. It can be the heart or the lungs. It can be the heart and the lungs. So I think, and for the patient, if we demonstrate the value, so, rather than seeing one specialist, then waiting a few months to see another specialist, it's like multiple VAR reviews in a football game. You're just waiting. And sometimes it's the wrong decision coming out of that as well.
Yeah.
So I think bringing that to a one-stop type setting, having both tests, in that one setting, it's great. It demonstrates value to the patient, the individual, but also the system. It avoids multiple appointments as well, isn't it? And the wait. And during that wait, we take it for granted that that person will remain well. That's not the case, unfortunately. They can go very unwell, end up in A&E, like I said, spend many days in the hospital. So there's value to the patient and to the healthcare system.
I think the value is also demonstrated in the partners that are involved. So obviously the British Heart Foundation is funding this. Very, very well-respected organisation, and they don't fund it if they don't believe in it. So there's something there, and the University of Liverpool are involved, and the NHS are wrapped around it. And from a Pumping Marvellous perspective as well, as a patient organisation, we've got to be interested in it. That's why we got interested in it way, way back when it first started, because we saw that there was some. And I go around and say this sort of thing is the biggest paradigm shift in heart failure care that we can give before 2030. And the reason behind that is that, we can talk about medications and treatments and care pathways and all that, acronyms and whatever. But actually getting people, getting the cause of breathlessness diagnosed, and getting people on guideline-directed medical therapy, whether it be respiratory or whether it be heart-related, is the most important thing, because then people can start. That creates foundations of less symptoms, less symptomatic, and therefore people start living their life. And that, for me, long-term conditions, living your life is the most important thing. So who am I going to ask here? Gail, what barriers disappear when healthcare goes into the community?
So we've talked about some of those practical barriers: parking, travel, taking time off work. If you've got to go to an appointment at a set time, you've got to take time off work. Whereas actually, if we've got something that's on over the length of the day, you could just pop in on your lunch break, you could pop in before work. It just makes those things a little bit easier. It's, looking after the kids, you might be looking after an elderly parent. Just having the time to go and do those things can be quite difficult. So I think having it in the community kind of takes a little bit of that away, which I think is really important for people to be able to access services when it's convenient for them rather than when it's convenient for us.
Rajiv?
Yeah, I think one of the things, this can't be a single solo effort. You need a team. You need Amy, you need Gail, who's a front runner leader in terms of the long-term condition space. So you need multiple partners as well. And without that, I don't think there's the sustainability or the longevity. So it can't just be the strikers. You need your Tarkovsky at the back, which is Gail possibly. You need everyone working together, because the thing is, we started this as a pilot for a few months. But now this is a long-term project, and that's the looking at it as a long-term project. You need the full team, and that's why getting multiple partners working together to ensure it is a long-term project and it spreads as well is the crucial bit.
So, I mean, some of the barriers are, for me. I mean, so if we talk about our Beat Street program, just very quickly, the 15 expressions of interest that we have around the country are all from primary care.
Yeah,
they're not from hospitals, which is exactly what you're doing. And I think that shows that there's an appetite, a real appetite for it. Just somebody needs to lead the way, and Everton in the community is that leader. It's where everything started, basically. And I think there's a big difference between the type of events that, so let's say mass heart health events, screening events, that sort of doesn't, it gets you to the point of maybe there could be something there, and then you're relying on somebody to pick that up afterwards. But what Beat Breathlessness Hub does is it sort of recognises, diagnoses and treats. And I know a lot of people are a bit sceptical about that, but it works, doesn't it, Amy?
It does work, yeah. I think once you get people in and it's recognising that a lot of those different symptoms, as you said, are all linked, especially cardiovascular health. So making sure that we are checking blood pressure and atrial fibrillation and giving them the opportunity while they're there just to cover the basics, as we said, but then just offering that extra test. Literally, it takes 10 minutes?
It's exactly what you said. It's about the prevention as well. We take it for granted, isn't it? So the blood pressure, the hypertension is a silent killer. But when you diagnose that and you can treat that or even prevent that, with lifestyle, simple lifestyle things, smoking cessation, improving fitness. So that's never to be taken granted. So I think there's the treatment, diagnosing and treatment, but the preventive bit, I would emphasize that as well.
Yeah.
Yeah, I mean, I'm thinking, I can't even think of a question anymore because there's so much opportunity.
Yeah.
I just think moving the needle to recognition, diagnosis, treatment is really important. And let's just be very, very clear here that these people are referred into specialist services that then define that diagnosis. It's not, we're not diagnosing and then back to GP. This is, these are people being referred into specialist services. So there is that safety net, which is very, very important. And there's a lot of conversation around AI, machine learning and all that sort of stuff. And I think it's really important that we as a team it's always having a specialist review.
Yeah, it's not a substitute for the specialist assessment ever.
And that's really key. This has huge impacts, certainly on wait lists, because who we are sending to the specialists from Everton in the community are really people who need help. Yeah. And we know they have a problem and we know what the problem is. We just, rather than, it could be, it may be.
Yeah.
Well, it is.
Got the evidence.
Because Rajiv has reviewed the scan and the AIs help interpret that for him at speed. Although he could do it anyway, we know that. And it gives us the answer straight away. So it has a massive system benefit. Yeah. So I think we're going to be doing another podcast soon about system. Yeah. But I think we've talked this through, and hopefully people who listen or watch this podcast get an understanding of where we're trying to go with this. I don't think any of us think that we can deliver it and roll it out and scale it to the NHS. We need help.
Yeah.
And therefore creating believers, and maybe people who listen to this from doubters to believers. There you go. I got one in. We'll pick this up and go, yeah, that may work in my area.
Definitely.
And whether you give Amy a call or Gail or Rajiv or myself and say, how do you do this? Or do you want a Teams call? Or you think, I can do this anyway. They've just explained what I need to do.
Yeah.
They're just gluing it together differently. And you know what? I'd love to get to a situation where you could just buy it from Amazon. Why not?
Yeah.
Why not? I don't know. another football club somewhere else in the country, goes on Amazon, pays for it, and it arrives in a box next day with all the training equipment and all the support that it needs. I mean, how cool would that be?
Perhaps even if it was just normal businesses every day. This is just how we see patients now.
Exactly.
You don't need to buy a
That's the
package.
bit, for everyone, to see that it's like Everton's motto, isn't it? Nothing but the best will do.
Yes.
Yeah. So if this can be the paragon, in terms of how it replaces care, that's amazing. And I think we should just thank, obviously, the British Heart Foundation to to have seen the value to fund this. Hugely grateful, and all the partners.
It requires some, it requires some guts to sort of, I'm not saying guts is the right word, but you know what I mean, to fund something like this, because it's relatively provocative, but it's really, really needed. And I love the clip you've just given us, because I'm going to make a clip out of that, Gail. That's amazing. Right, thank you very much for joining us on the sofa at the Liverpool Podcast Studios. Thank you very much for the British Heart Foundation for funding this amazing piece of work, and the key delivery partners being the University of Liverpool, Everton, the Community, Pumping Marvellous, and all the other partners that are involved in this as well. So thank you very much.
Thank you.
Thank you.